So much as I'd love to keep this conversation going, I think we need to turn the stage over to Larry Minnix. I've asked Larry to give us some reflections on what he's heard over these last 3 days and to leave us with a sense of hope about how we can move this forward. So, Larry, thank you for being here. Thank you for sitting through all of this with us, and please go ahead.
Well, thank you. And it's been interesting for me, having spent 40 something years in all of this and being a part of the original group, to see this new generation of smarter, more talented people that bring everything from research to practice to bear on the issues involved. I came to the conclusion somewhere yesterday in the middle of one of the discussion groups that we know what's wrong, we even know what to do about it. What we're missing is an organized approach and focus. There was someone who published um, performance evaluation excerpts from federal employees as a comedic kind of thing, but actual things that people have said on the record about people's performance. And this one supervisor wrote about an employee, this person has a full six pack. They're just missing the thingy that holds it all together. And I would say that Advancing Excellence has a full six pack. We need a couple of thingies to hold it all together as we go forward. That's my first kind of observation. The second one is the era we're in. 80 years ago, we were in the rest home, home for the aged era. With Medicare and Medicaid, we got into the reimbursement era. That is, we did what the government would pay for. Then we got into the regulation era, and that was a lot of complaints and rebellion, and we lived through all of that with over 87. The next era, which I think Advancing Excellence helped to introduce, was the quality improvement era. And that was the crucible out of which this group was born. People that wanted to improve the quality and stop complaining so much about the regulation. And I think we're on the cusp of this new era, which I would call the consumer focused era. And by consumer, and it's just laced throughout all of your word salad things here. Consumer is the resident, the family, the caregiver, paid and volunteer. This is all now about the people and what they need and want. Now, an analogy that I would use is that zoos finally had to move from being zoos to natural habitats. And I think what we want to do is create the equivalent of the natural habitat for those people who have to have some kind of safe, contained environment. Now, I want to suggest to you two big, audacious goals, because that's what we've been talking about the last few minutes. The first one of those, and let me say, you're going to be on the front end of a new administration. And those of you who've been involved in the politics of it, you have about 1 year in a new administration and a new Congress to establish relationships with the credibility you have to make big change. After that, things get cemented in. And then you start dealing with turnover of people that you related to in the early place. So you got 1 year, I think, to establish a new beachhead of what you want to get done. And I would say that what you want to get done, we started with the Bush era and Thomas Hamilton, who was head of Survey and Cert, who wanted to work closely with a number of groups, especially the Pioneer Network and the rest of us, to redefine quality measures around culture change. And that got off to a pretty good start. I don't know whatever happened to it, but I think we want to go back to CMS and say we want to redefine the nursing home and nursing home care, and we want to address the quality issues that are obvious that have cropped up in every newspaper in the country, and we want to address uh, the um, the issues of disparities based on race and class and other things we've been talking about. And we want to say to them, we want to put a plan on the table with you that would transform nursing home care to be what it can be. And I would do it around 5 domains of quality. One is quality care itself, the clinical, the environmental sanitation, the client experience. We need to know what people like Maurice and his family and so forth think of what we're doing and need to document it. And staff. We need metrics around all of that in real time. So one quality measure or domain is quality care. The second is culture health. And that is the focus here, as I've been on direct care staff, as the most important focus we can have. Don't lose focus. And if you can improve the plight and support and respect and so forth for direct care workforce, that's the thing that will be the leading um, driver to change the world that we live in. So I would put culture metrics. Um, I would include in the culture things like justice mechanisms. I've had some experience with that with my former direct care organization, Wesley Woods, where we put in place things like a pre-discharge review. Nobody could get fired precipitously, and that had a remarkable effect on the workforce because people didn't have to be necessarily afraid that some white supervisor that had it in for them could fire them over a weekend and they'd be gone. So we put in other mechanisms as well, but I'd say justice mechanisms, compensation, recognition, and ambition. Not everybody wants to be a head nurse, but everybody wants to advance and get better at what they do. Um, and compensation, I agree what's been said here. You know, you got to start somewhere. I'd start at $16 and say in 5 years, you're going to, or ever how many years, you're going to move it up to a base of something else and indexed thereafter every year. And with reimbursement increases, the increase in the reimbursement ought to go first for direct care before it goes to overhead and profit. Um, I'd be measuring retention and turnover and find some metrics to measure diversity and inclusion. So culture health, quality care, culture health. The third domain would be the environment itself, and I'd be organizing that around greenhouses and neighborhoods. The physical structure of nursing homes today, and most of them, is just not adequate. And in fact, it you couldn't build a place to spread disease faster than most nursing homes are designed today. Nobody intended that way, but there were many hospitals. They got wings, semi-private rooms, et cetera, et cetera. I'm on the board of an organization, AG Roads, as you may know, and also Trinity Continuing Care, which is a Catholic nonprofit national organization. And they've done a remarkable job of controlling this virus and included modification of physical space. But I'd be every new long-term care facility or community needs to be built around what is now becoming tried and true principles inherent in greenhouse and neighborhoods. I'd be measuring in that environment the dining experience. Food is the most important part of everybody's day, whether they live in a nursing home or they're sitting here in my dining room. The meal experience is key to the way we feel about the quality of our lives. It doesn't have to be delivered at a particular time, as the regulations call for, but I do want it to be delivered in a way that I can enjoy it with my family and friends and so forth. So I'd be measuring the experience. I'd be trying to figure out how to define a home-like setting. I'd have metrics in there around people's perception of the spiritual care that they get. Every physical facility ought to have some kind of spa amenities, and it ought to have some kind of isolation infection control capabilities. So that's the third quality domain. The fourth is ethical reflection. Every organization, I think, needs an ethics committee. They need a whistleblower policy, a grievance committee, um, and transparency of reporting, annual reports, um, and disclosures about problems that may arise and what's been done to resolve them. So the fourth quality domain is ethical reflection. And the fifth one is accountability, governance and ownership. Um, I got in an argument one time with someone who was part of a Wall Street chain that was owned by some kind of a financial entity, and we were at odds over a particular piece of public policy that Congress was struggling with. And I said there ought to be if I was at Wesley Woods and somebody's mother got a bad experience over a weekend, I heard about it. The president of the university or the bishop or the head of the women's society at the Methodist Church or my board chair who was a vice president of Coca-Cola, and I was expected to fix it immediately. So you tell me who among this financial conglomerate that is worldwide and wants to be on call every weekend to take those calls. And if you give me that name and somebody's going to be available to stand accountable for the care you deliver, then we're getting closer to being on the same page. Um, um, Survey results. And I think it needs to include more of client review and peer review. There's some good accreditation stuff out there. The Methodists have an accreditation, CARF, JACO, that cover a lot of these domains that I'm talking about that oftentimes Survey and CERT, while it covers fundamentals, does not cover. And I think we need to take into account social media reflection. I mean, most of us don't buy a product or a service that we don't go on Yelp or Angie's List or whatever to see what people think about it. And that's instant accountability. So those would be the 5 domains. I'd go to CMS and say, we want to work with you on redefining nursing homes and how to make them stand accountable. And in the process of doing this, we want to recommend to you a second big goal um, that is dealing with the disparities. There is a mechanism in hospital services called a critical access hospital. A number of years ago, we pulled together all of our predominantly African American communities throughout the country to see how they were faring, because many of them were in the inner cities and were having a very difficult time of it. And we learned an awful lot, including the fact that they were essential to the neighborhoods and the cities in which they existed, but their reimbursement was getting was getting less and less, and the complexity of patients they were getting was increasing. So we kicked around the idea of creating a category called critical access nursing homes. If they leave that community, care and services for vulnerable, especially people of color and poor people, was going to disappear. Where would those people go? Would they be dispersed throughout a metropolitan area? Be very difficult to do. Jobs would leave. Families who depended on them just like they did schools to put their kids in while they go to work depended on those particular communities to make it. One community took that concept to their state, and the legislature gave them additional reimbursement because they were essential to their community. I believe that we would say that there would be critical access nursing homes in urban and rural areas. Rural has poor people, people of color and white, but those folks have no place to go, and yet they sometimes are the only healthcare facility of any kind in a multi-county area. So I believe that we've listed a bunch of things that are important to do. If a strategy is a mechanism by which you can accomplish a number of individual objectives in an experimental kind of fashion, and I recommend you especially pursue CMS around redefining nursing home care around contemporary um, um, uh, um, practice, and they might be open to that. And I would recommend that you explore the possibility of some kind of defining of inner city and rural as critical access. And by doing so, you take the care to people who are in the disparity group. You don't try to find ways to get the people in the disparity group to come out and go be dispersed throughout the hinterlands. Pace did that when it started. It didn't bring elderly Chinese people into programs all over San Francisco. It took a program to their neighborhood where they lived and developed the program there. Similar kind of approach. And I know we had some success with CMS with under the Hamilton era, and they might open to that. And God knows, everybody knows, nursing home care um, needs to be redesigned, redefined, redesigned, and around the Maurices of the world, as opposed to us designing something and expect Maurice to move there. So, and as I'm listening to you guys and looking at your credentials, I'm thinking to myself, if if not you, who? Nobody else is going to do it. Now, the biggest thing that'll get in your way, I have found in creating any kind of um, collaborative beyond a coalition or a cohabitation or a confabulation or whatever, because there are a gazillion of those in Washington. The thing that makes a collaboration is that every party has to be willing to give up a measure of their control over things in order to accomplish something for the greater good. That's the most difficult challenge that you're going to have in getting any of this done. And we had it with advancing excellence in spades when we first started around the conflict that had pre-existed between some consumer groups and some provider groups and some labor groups. These are groups that would hardly get in a room together, but we did, didn't we, Jake? And created something together that none of us could have created otherwise. So your biggest enemy, biggest challenge is going to be yourselves and your relationships, because you're certainly not lacking for brains or motivation or commitment or passion. You're not lacking for any of that. And God knows you got to get this stuff fixed because I'm getting old. And And I don't think, even I'm on the board of AG Roads, I don't think they want me. I read a bumper sticker one time with a young woman in the car that had her grandmother over next to her, and there was an outline of a wheelchair on the side, and there were two little kids in the back seat, and this young woman obviously was, I assume she was the granddaughter, and she was having to take care of two generations, one above her and one below her. And she had a bumper sticker that said, "Heaven doesn't want me and hell's afraid I'll take it over." And Rhodes doesn't want me, and so that means you got to get this thing fixed before I get too old and need what you all have to offer. So those are some of my reflections. Other than that, I didn't pay much attention to what I heard, but I'm very encouraged by what I hear. But you got a big job. The question is, will you do what it takes among yourselves to do it?
Larry, who are you talking to at CMS that they want a new model for nursing homes?
Model for what?
What you said. Is there somebody at CMS that you're talking to about this?
No, I'm in a little community called Avondale Estates, Georgia. Retired for 6 years and following all this in the newspaper, Rosemarie. I'm just reflecting on the progress that an earlier rendition of this group made with CMS around redefining the rules around culture change. And there was an era there in the Bush era in which they were open to doing that.
Right. Okay. So we don't know. We don't know.
We don't know, but I would say that if you don't establish your credibility and rapport around what you want to do in this first year with the Biden administration, the door will close on you. There'll be an unfreezing, and that's where you got to move in with something that you think you can get done with them. And in a year, it'll refreeze, and there'll be turnover, and you'll be at that point negotiating for nickels and dimes and small changes in rules for the next 3.5 years.
Yeah. Thank you.
This organization, this iteration of Advancing Excellence and its members have had some contacts with the administration versions of CMS and CMMI. So I believe Leading Age and American Healthcare Association and AMDA and others have started having some of these conversations about appropriate new payment models for nursing homes. But I think Larry's point about the connection with the new administration and this as a new opportunity to jumpstart some of these critical conversations is really important.
And keep in mind, you look at the examples, greenhouse alone, there are about 350 successful greenhouses in the country now. And that model works. It works clinically, it works from a customer satisfaction standpoint, from a staff satisfaction standpoint, and financially. Many of these places are living within what Medicaid will pay them because they have changed the culture and they've addressed these respect issues and so forth. So there's something to, I'd call it the greenhouse neighborhood concept. Environment dictates a lot of people's attitudes and behaviors and so forth. So you're not without some example stories, if you will, that you can share successfully with CMS.
All right. Well, I know we're a little bit over time, but I know we could continue this conversation for a long time. But
you can always count on me to take you over time, Chris.
Well, thank you, Larry. And
I admire what y'all are doing more than I can tell you.